Thank you so much. Welcome from all over the country. I see you're coming from. We only have a power hour, so I'm going to go ahead and jump right in. I'm Laura Ornelas.
I'm sorry,
I
Laura. I'm sorry. Hello, everyone. I see Erica Barrett has her hand raised. I just want to make sure there aren't any issues. Erica? No? Okay. All right.
Great. So if you have anything during the webinar that you have questions about, Joaquin's going to be here and you can private chat her. Does that work for everybody? Okay. Welcome. Wow, there's people from everywhere, Joaquin. Shall I go ahead and jump in?
Yes, looks like you're doing good, Laura. We have people from all over. Welcome, everyone.
Okay, you are all in the right place if you came to understanding the complex mental health needs of youth adopted from child welfare. So as I said, I'm Laura Ornelas. I'm one of the case members that works on the National Center. And today I'm here to share a little bit more about the clinical side of working with this population. So I'm going to assume that a lot of you out there are clinicians, but I'd be very interested to hear otherwise. So if you don't mind putting in the chat what professional background you have, that would help me to gear my comments as well. So go ahead and just put in the chat what your role is, if you're a mental health clinician or if you're in any other role or have any other background. Okay, wonderful. Thank you. I see people with all kinds of different roles in here. Oh, there's even an attorney. Okay, wonderful. People in post-adopt. Okay, got some mental health folks. Wonderful. Lots of foster care folks, support folks, wrap people. The roles are always different depending on where in the country people are coming from, but I think we've got quite a range of professionals out there, so I will gear my comments accordingly. Okay, first I'm going to start off with a quick question. How many of you have already taken our NTI class? If you've been on the center website or if you've been engaged with CASE in any way that's leading the center, you may have already taken our NTI training. Can you go ahead and just light up the chat? I know we can't see each other's faces today, so I just want to make sure that you stay engaged. Many of you have taken NTI, and some of you are still engaged. Okay, we're going to be giving out information at the end about our NTI class. If you have taken NTI, or even if you've taken our TAP class, this might be a little bit of a review, but I think it's an important starting place. We're not going to be able to do any deep dives today just because of time, but we'll definitely cover some ground in terms of why working with this population is different than working in other settings that you might have worked in and why you might need more knowledge and skills to be able to do it. Okay, so we're going to go ahead and keep moving forward, Joaquin. We have set out just a few little lofty goals today to be able to give you some learning objectives in terms of understanding a little bit more about the complex needs that are facing children and families. Families are an important part of this work. If you are not already working and heavily engaging with parents, that's a takeaway that I hope that you walk away with today. Today, also to learn how to better support children and youth who've experienced foster care, as well as the families that serve them, and to identify the strengths of using an adoption competent specialized mental health approach with children and youth and families who've been adopted from the child welfare system. Okay, so that's what we're here to do today. And you're welcome to come back and watch the recording or again to dive into our NTI or TAC classes if you haven't already, because that's where you're really going to learn more about every area that I'm going to be talking about. So why is it so important to learn more? I'm sure many of you have lots of years of experience. It's important because no matter where you are in the system, you are going to be experiencing this population, children and families who have either been adopted, whether you've known it in the past or not. Sometimes people haven't even necessarily asked that question. To Children in foster care, if you're actively in that role. And then importantly, sometimes a population that is forgotten, which are kinship caregivers. They might be grandmas, but they might be any other age range of a relative or a near kin kind of a person. So somewhere, or maybe everywhere, you are touching this population. So you're welcome here. Thank you for coming today. The research indicates that foster and adoptive families are significantly more likely to work with mental health professionals. And that's how I knew also that you were touching these families, even if you don't work in a specific foster adoption or kinship caregiving setting, and you're not in a more generalized setting, because these families are seen at 5 to 8 times the rate that a family who does not have this background is seen. Adoptive families are 2 to 5 times more likely to use outpatient mental health services, and children and youth are 4 to 7 times more likely to land in a residential treatment center kind of a setting. And recent research is indicating, and this has been ongoing research, that if you go into a residential treatment center or setting, that a solid 25, possibly even 30% of the children and youth there will have this background. And there's a lot of reasons for this. Next slide, please. The primary reasons are the pre-placement risk factors that have existed when they came into foster care in the first place. Children were with their birth or first families who had a lot of vulnerabilities, right? If they've been adopted, that happened for reasons, long-standing, probably very vulnerable kinds of situations, often which experienced trauma and loss. Also, the prenatal and the perinatal conditions that children experienced play out throughout the life course, right, of their development. And so the reality that they might have experienced things like malnutrition, that they might have come into foster care with low birth rate, that they many times, as you all know, have come in exposed to drugs or alcohol. And unfortunately, all kinds of maternal stress has been experienced from things like violence in the home, in the community, in the family, et cetera. So our children, even before they enter the permanent family that they now live with, luckily, have experienced early deprivation. And then unfortunately, because of the stressors these families were facing, some adverse parenting, right? Whether it was neglect or whether they ended up in any kind of institutionalized or group setting, they did not have the same start in life that other children have been able to have. And so they're very vulnerable. And then they might have experienced any multitude of traumas thereafter, any kind of maltreatment, whether it was physical, sexual, emotional, psychological, developmental kinds of traumas. Unfortunately, as you also know, children in foster care have had so many multiple moves. And so whenever we use that term, it's not just a word. It's so important in adoption competent care to be able to dig into that history, to understand how many moves, how old was the child during that period of time, because all of those impacted their development. And there's no getting away from that. And the messages that they received from any one of those different parents or caregivers has all been internalized by that child. And I really want to pause there, and feel free to comment in the chat if you'd like. But this is a huge takeaway when we are working with this population. They didn't just get transported into their permanent family. The moves that they had matters in their development. It matters in terms of how they perceive the world, and it will play out in terms of their relationships and their behavior. So it is not to be underestimated. Unfortunately, a lot of people who provide services to these families don't understand the histories and how huge of an impact they have, and how complex the presentation it would be, or could be, or often is. And so oftentimes it's the professionals who unfortunately have gone in the wrong direction, who steered families wrong, who've who provided treatment that really isn't accurate or on target for kids, without taking into account their history and their losses and their traumas. And so some of the things that have happened, research shows us, is that it's unfortunately our mental health community that hasn't validated, believed, or spent enough time caring about the experiences that they've had, and kind of jumped forward into the present day. Other things that unfortunately our professionals have not been able to really accurately address is what's going on with their current parents and their caregivers. And they're looking at the permanent parents as potentially at blame for what's going on. And even though the family systems approach is incredibly important and foundational to this work, there's a very fine balance of supporting our parents and really including them in the process as opposed to blaming them. And when I use that term, I'm really talking not just about with them, but to each other and behind the scenes. That's something that we all know is done. Also, pathologizing permanency. This is an important reality that sometimes, because families have vulnerabilities, because they have needs, that they've really been pathologized. There's nothing that's wrong about an adoption or a foster care or a kinship caregiving family. But there are obviously stories that come with the histories that can create different kinds of challenges that we need to hone in on. Unfortunately, parents haven't been given enough support oftentimes by mental health professionals, and some will even go so far as to question the parents and why they did this. Some will even go so far as to suggest that children are returned back. And if you just think about the reality that likely no mental health professional would ever say that about a child who was born into the family, I really want you to think about that one, about the profound difference that perhaps a child who's been adopted has been treated with in terms of even just having that viewpoint, how that lens could potentially affect the course of treatment if the therapist and the professionals are holding that belief, not just the family, about returning a child into foster care. The reality is there is a small percentage of children that do come back into foster care, but in those rare circumstances, it's hopefully with tremendous support of professionals who agree that at any given time that it's not possible for a child to live in a family setting for some temporary period of time and with connections still being maintained with a lot of professional support. So that's not the same as what I'm talking about here. What I'm talking about here is a child who's come in for outpatient mental health therapy, and the therapist suggests this as an option where it wouldn't be an option in another family situation. So the other part to the story is that children who've had multiple moves and who've had breaks in their attachment are going to be logically very vulnerable in relationships with others. And so it's so important that our therapists and our mental health providers, whatever your role might be, are honing in on the relationships that children are having, both with their parents, caregivers, with siblings, with friends, with peers, with teachers, etc. Community is incredibly important, but it isn't paid attention to by all mental health providers. And another one that's just on this list that you see before you that I already referenced is failing to get enough information about the child's histories, because again, that is a very important part to the equation. The child didn't just show up or get born with these particular behaviors. So where we're going now is to talk about solutions and ways that we can correct for some of the challenges that have existed in our mental health profession. And I say that as a licensed clinical social worker. I say that as part of the problem, having learned the hard way that we have a lot more knowledge and skills to learn out there around adoption competence. So we put on the screen for you what adoption competent professionals need to have to work with this population successfully. It's a long list. It's a wordy list because this work is complex. This is not a one and done kind of work. This is very much a comprehensive approach. It's going to require trainings in all different kinds of modalities. It is not the kind of approach where you can get trained and just be able to do it in one shot. So there is not one evidence-based practice that can address the multitude of needs and complexities that this population is bringing in. And remember, when I'm intentionally using this word population, because I'm referring to children and youth, I'm also referring to all the members of their family system, those that are being touched closely by them, and importantly, the parents. So I'm just going to slow down and read this list for a minute, okay? Because people confuse what adoption competence is because it's deep and it's wide. So I have this wordy list up here for you to be able to really lean in and digest some of this information in terms of what are the competencies of a person who's really able to provide this care successfully. The first and possibly the biggest is that adoption competent professionals believe that healing occurs best within the family. So we take a family systems approach. And when I'm out there training mental health professionals across the country, I can tell you that this is one of the hardest pieces for them, that they are often, as probably many of you are often, to working alone with children. And the reality is that children are existing within family systems, and it's within the 24/7 of family care where the child's changes are actually really going to be able to happen. It's with those patterns, it's with those experiences that are being created in their permanent family where actually they're going to be able to learn new ways of behaving. It is only in a small way going to be happening in our therapy settings, which is why it's so important that we recognize, we honor, and we elevate the families. So hopefully you had a second to read that second bullet, that family-based and attachment-focused approaches are critical to addressing the trauma and attachment. Why? Because for all the training and for all the knowledge that we have as mental health professionals, again, the parents really need the skills. The family members need to be able to do this in family life. It's not something that we can wave a magic wand and do. And I know that as I say that, many of you hopefully feel a sense of relief because it's not all on you. What I would invite you to do is, yes, feels that relief and be able to lean into your work, especially with the parents and the family members, because they are the ones that need the knowledge and the skills. And when I say that, we're not talking about talking at the parents. We're talking about really helping to engage them and help them to understand the needs of the children. This is the hardest piece. It's going to require training. It's also going to require a lot of practice, and we will have opportunities for that practice in this center for you. So keep engaged with us, and you'll keep hearing about those free opportunities. Okay, so you need a range of understanding of trauma, of loss, of the grief work. We're going to talk about that in a few minutes, of attachment, and importantly, identity formation. The complexities that go in to this child and developing youth into who they are is a massive question for somebody with this kind of background. Even for somebody who was adopted as a very young child, but especially for children who've experienced multiple moves, now becoming teenagers and trying to figure out who's my family? Who am I made of? Who are the people that I'm connected to? Very complex process, and they need a lot of support specifically in their mental health treatment around figuring that out, which again requires their therapist to lean into this area. So if you're doing that, that's awesome. If you haven't been doing that, again, further training in that area would be really important. Another important hallmark of adoption competent care is that we recognize that these challenging behaviors are a result of the history and the experience and their exposure of children who've come into foster care. We talked about avoiding blaming the parents. And when I say parents, I'm talking about all the parents along the way. Also, that the parents are so critical now, whoever are their permanent parents, and to support them in learning therapeutic parenting. Therapeutic parenting is, again, a comprehensive way of parenting. There are a lot of approaches out there that can help, including the NTDC, which is a national curriculum that we help to create for parents. You can learn more about that as a resource. Also in the area of communicative openness. So research shows us that families who are more likely to talk more about the adoption story, the permanency story, why this child is being raised by relatives, et cetera, that they actually are going to have healthier family functioning as a result of being open about that. That's the communicative openness piece. It's so important that kids are not left to figure this out on their own because they don't have the developmental ability to be able to do that. And instead, they end up often blaming themselves, which is one of the areas that we end up needing to work a lot on in mental health care, which is that sense of self-worth and that sense of self. So anybody out there, most of you working with these kids, hopefully that resonates with you. And this is why we need as practitioners to help them make sense of these experiences, right? That meaning making is so incredibly important. Not just that they understand it, but that they understand it as it relates to who they are as a developing human being. Really critical. And that we assist parents in understanding that, to have an in-depth understanding of, first of all, the experience, but also how that experience affected the child's development. That we're all deeply trauma informed, that we all understand our neurobiology of trauma, that we're able to talk to families about that, that we're able to talk openly and understand how that affected the child's brain and physiology. There's a lot of great trainings, including ones that we have in this area, because in and of itself, that trauma informed place is incredibly profound. And it's not the whole of adoption competence care. We actually have a new resource that we just put out in the center that talks about the importance of trauma-informed care and how it fits within the larger, more comprehensive framework of adoption competence. Another hallmark of adoption competent care that's really, really important, acknowledging and honoring the connection to the child's past and their current relationships, whether it be with their birth or first family, with kin, with connections that help to support their identity formation, any kind of cultural connections, et cetera, to attachment to others. And then importantly, the realization and the reality that this is a lifelong consideration. And I really, really want you to hear about that. If there's a handful of things that you take away, this journey is lifelong. So not just looking at where the child is in the snapshot of time, this vacuum, this age, this phase, but rather how is this going to impact their whole life story? Where are they going? So when we decide to make connections or cut off connections, for example, how is that going to be impacting them at a later phase? How can we help them to understand and process what's going on with that connection? So that's a very important point of this work that may or may not be done in your mental health practice, and I really encourage you to do more of that. Also, again, with the identity development piece, recognizing the importance of and demonstrating sensitivity to and respect for the child's heritage, their background, all these developing identity layers. And then lastly, which is not to say leastly, because all of these are incredibly important, is collaborating with other systems. This is not work that's one and done. This is not work that can be done in a vacuum. If you're a private practitioner out there, really encourage you to be in groups and in trainings that can allow you to consult with others, because these are very complex cases that we're working with, and better minds and more people on these cases can be incredibly supportive. You're not in this alone either. And it's important that you don't try to do it all yourself for our complex cases. We really need more hands and more minds, the more complex that a case is. Okay, so I hope I'm giving you lots to think about. I'm going to take a breath there. We are going to be culling your questions. Of course, we can't answer them all from all of you, so that's what we have the center to be able to get you more answers, but you're welcome to put them in the chat so that we can record them. And even if I can't get to them at the end, we'll be happy to give you more information about them, and we will save a few minutes at the end in hopes that we can answer at least a few of them. Okay, so feel free, if this is bringing up thoughts, to go ahead and put those questions in the chat or comments. All righty, so we're going to move on now to the next slide, which has to do with positive experiences after our families have experienced some of the care that I was just talking about. So I talked to you a few minutes ago about some of the adverse experiences that our children and families and adult adoptees, transition-aged youth can experience, right, when we don't have the skills and the knowledge that we need. So now I want to just share a little bit more when they do have the training, when you all do have more and increasingly advanced trainings in adoption competence, some of the results that can happen. So in a study that we recently did with through our TAC training, which is a training that we developed for practitioners after they took NTI, you can see what we learned from our group around TAC trained therapists and our control group around those who did not have the training. This is what families reported. They reported things like higher satisfactions with the services, which tells us something about the quality of treatment they were receiving. That we found links between client outcomes, such as a reduction in their emotional challenges as a result of doing the kind of adoption competent work that we're talking about. Remember that family focused approach, that parental engagement piece, all those other areas of adoption competence I just named. That's all what's going into this higher level of satisfaction. Another area that they ranked more highly in is greater therapeutic alliance and higher levels of engagement, including more parental involvement in treatment. Now, why is this so important? It's so important that we push ourselves in this area with parents because they are absolutely at the heart of potential change. They really are. Again, the families, I can't say this enough time. The family setting is where the child is going to learn new patterns from their past. It's the only way they can do it. We can't do it alone in therapy. We need our parents and we need to give them support because this work is really, really hard. So the parental engagement piece is hard, and we understand that sometimes that's where practitioners are really challenged. And so again, more trainings that we have and more supports through the center, we really welcome you into to learn more about this parent piece if you're not used to doing it. It's really critical to outcomes. And the parents felt it in the TAC trained therapists that they were being exposed to. So we also saw positive outcomes in family measures. Again, that communicative openness, which, by the way, is linked to adoption breakdown. So it's not just something that feels nice, it actually demonstrably changes outcomes as it relates to children who unfortunately need to come back into care, need to get moved families, right? The talking about understanding my story, really important piece of the clinical work. That they had more understanding of adoption knowledge. And whenever I say the word adoption, I'm also talking about permanency. So that could be a guardianship, that could be a kinship caregiver, all of that. This is not adoption as a legal entity that we use this word adoption. It is a heart connection that I'm referring to because I'm a clinician and I'm speaking to a lot of clinicians and people who provide direct services to families. I know we had one lawyer on the call, but with the exception of the legal folks that are out there, we're really talking about adoption as a permanent heart connection in this kind of clinical conversation. Okay, also improved outcomes in families' relationships with one another, because again, the family focus is so important. Now, I don't have time today to share with you too much on families, but I think that you all know, coming from families yourself, that family dynamics matter, especially if there are multiple adults, multiple children in the home. For example, is any given child that you're working with, youth, teenager, are they being exposed to siblings? Are those siblings also adopted like they were? Are they coming from different foster homes? Are they all coming from different kinds of biological backgrounds? Is there a mixture of children who were adopted, who were kin caregiving, or children coming or currently in foster care? All of those dynamics matter greatly in the family configuration. So are we talking about that? Are we working on it? Are all the kids in the family getting support? Or has this one child been identified as the person with the problems, which is a problem in and of itself? Because again, they didn't do anything wrong. It wasn't their fault that they came to foster care. But unfortunately, we have not always treated them that way. And unfortunately, their parents haven't understood that, which is why they need more support from us to be able to understand that. Okay, so this is the power of adoption competent care, everybody. So in the next slide, you can see that in another survey we conducted, that we saw the experience that families are actually having out there. So when we surveyed almost 500 families, we could see that less than 25% believed that their therapist was adoption competent based on the experience that they were having. That 50% believed some of the therapists they worked with were adoption competent, but many of the others were not. And 26% believed that none of the therapists they work with were adoption competent. So this is not like private information where the families can't tell the difference. They can tell the difference. They can feel the difference. They know when they are and are not receiving services that are on target to the actual needs of their family. And so that's why we created the center, because we understand at the center about the needs that our professional community has in trying to meet the very complex needs of children and families. So we're so glad you're here. Really want to pause to take a minute to appreciate you for taking this hour out of your day to learn more. And I'm being serious about that. Everybody take a moment right now and thank yourself for contributing to your own knowledge and understanding. Okay, you are doing something really good for children and families by being here. Thank you for being here. All righty, we're going to move forward now. And I just want to give you some clinical peeks into treatment with children and youth with these backgrounds. Okay, so just take a little look at this list and see if any of these, I'm going to say symptoms, because this is a mental health community here. Do any of them look familiar to you? Take a minute to read that list. Okay, so as you look at those difficulty with transitions, difficulty making decisions, feeling and seeming overwhelmed. Thanks, Oriana. She says, yes. William says, yes, the difficulty with transitions. Yep. Depression, anxiety, fearful they won't be safe. They're going to keep losing people. Learned helplessness, hopelessness, social isolation, guilt and shame and anger. Yes, Regina, letting go of unhealthy relationships. We absolutely see that all the times. Yep. Jeanette, challenges with their developmental skills. Anger, confusion about what happened. Again, that lack of clarity and the need for them to understand more. And here's a really important takeaway. If you are not already opening these conversations yourself as a professional, some professionals have historically been trained that we should be waiting for children to ask. This is not a specialty where we wait for kids, and we teach parents not to wait for kids, that we are the ones as the adults that open these conversations. That's what our research around communicative openness has taught us, that it's really important that we are the ones to be able to ask questions like, are you thinking about your birth mom? Are you thinking about your family? Are you feeling something about your birth mom, let's say, on Mother's Day, for example? Are you thinking about them? We're about to approach the holidays, everybody. Are we talking about their past experiences, their cultural connections, different families they might have been in? All of those things are what comes into adoption competent care in terms of areas that we might cover. So getting back to our list here, if these symptoms are looking familiar to you, for some of the children and youth that you're working with, I want to show you something that you may or may not know. Before you advance the slide, Joaquin, I just want to have you kind of think about this, those of you who are licensed clinicians, diagnosticians out there. Some of these could be interpreted as diagnostic, right? Feel free to throw in the chat if you might kind of associate any of these with any particular diagnosis. And I can't see all of the chats, so I'm just going to ask Joaquin, if you see any, you want to go ahead and call them out to me? Anybody have any diagnoses that these kinds of symptoms are bringing up for you?
Absolutely. So we have PTSD, we have ASD, ADHD. Probably, Jeanette says probably any transitions and changes could equal to autism, but lots more. We have another, Chelsea says PTSD, adjustment disorder. Anyone else?
Okay.
ODD.
Mm-hmm. Yeah. Okay. Thanks,
Oh,
Joaquin.
Megan. I'm sorry. Sorry about that, Megan.
Okay. Thank you, Joaquin, for reading those. So these are all very common diagnoses for our children and youth, and we're going to talk about diagnosis in a minute. What is often missed by clinicians, and I'm not saying this is what you are missing, but we'll show you some outcomes from trainings in a few minutes, and you will see that our clinicians across the country very frequently miss what this compilation of symptoms is indicative for us in adoption competent care. You can go to the next slide. These are common symptoms of ambiguous loss and or unresolved grief, everybody. So when we literally look at that list of symptomatology and we understand more about what loss looks like for a child who has been taken from their birth or first family, when they have come into foster care as a result of tremendous vulnerability and hardship, when they have needed to move potentially even more times than that, and when we have layered in additional traumas to their brains and to their bodies and their hearts, this is the kind of thing that starts to weigh in to the presentation that we see. One of the huge core areas that clinicians, however, do not often address is the tremendous loss that accompanies all of those kinds of experiences that I was just naming. Okay, so grief work is a hallmark to adoption competent care. And that's really different from many of the other places that clinicians go because we are faced with these big behaviors. It is not our instinct and sometimes not our training to be able to actually get into the quiet, much more subtle grief work that's involved. But the reality is that every child that you're working with, yeah, Irma's saying deep loss, yes, the deep kind of work that we're talking about, it's profound grief that often needs to happen as part of or supported by the therapeutic process. Okay. The losses are unending for these children and families. Okay. And yet we do not necessarily get this as clinicians oftentimes. The most profound loss, of course, obviously and sadly is not just the loss of the people, which is massive, but it's the whole opportunity, the whole experience of growing up to the people that you were born to, that you're genetically connected to, and having the entire lifelong journey without them for the most part. So it is deep and long and large. So next slide. We can talk in a simple way in terms of primary losses, just to start to get, an example of some of the losses that our children have experienced or are experiencing, or even as they move into adulthood, continue to experience, because as they start to realize the losses, they often get re-triggered and re-traumatized again. And they have developmental grieving needs now for the people, for the places that they used to live in, that they used to frequent, that they used to shop at. And those might not be pretty places. Those might not be the kind of places that you are, thinking that they would miss, like, a nice clean room. It might be, a dirty blanket or something. We oftentimes forget about pets. We forget about toys. We forget about furniture. We forget about things that they loved in addition to people and nonverbal kinds of things. And the list goes on and on and on. But sometimes I think about it like a witness protection program where you lose everything and your identity totally gets changed. And unfortunately, the younger the child, it's not that they do or don't have less loss, it's that it is often less recognized when they do. And it's more of a felt experience that they're having, which is even harder to name. Because with older children, possibly we have the opportunity to put words around it so that we can do some of the grief work. So if you're working with children or even young adults who've been adopted and they're not able to put words and actually look at the experiences and the people and the places and the things and the connections that they've lost, then it could well be that this is what's been experienced, that they had those losses at such young ages, or that they were so profoundly impacted and traumatized when they had the losses that they haven't even been able to shape language around it. The list goes on, everybody. They are continually, you can move to the next slide, please, experiencing a loss of anything that you might see on this list or all the things that you see on this list. So if you just start to reflect on this list, you can start to realize the entire global impact. If you just relate it to yourself, right? The impact if you were to lose every single part that is on this list that would impact your connections, impact your sense of self, impact who you think you are, impact your heart in terms of your relationship, impact your support, your identity, all of it. And then this theme of all of these profound losses, again, which play out over time, not just in this one period, which is what unfortunately has been perpetuated as a myth of adoption. It doesn't just happen the one time when they get placed. It creates a theme in the child's story over and impacting their development. And that is what we see in our mental health settings over time, no matter what age the person now is. Okay, next slide, please. So sometimes we refer to the emotional or psychological impacts, especially for the clinicians in the room, as the 7 core issues. This has been a wonderful contribution to our field by some colleagues of mine, Dr. Allison Davis-Maxon and Sharon Kaplan-Roja. The loss is massive, and as you can see, it continues to beget other issues and considerations and vulnerabilities. So a sense of rejection. Think about, some of the people that you're working with as I name these, the shame and the guilt we talked about a moment ago, the grief. And when we talk about grief, reminding to everybody who hopefully, you're a bunch of professionals on this call, so I'm sure you know that children, the presentation of grief looks different. But even in that last slide that we saw about grief, a lot of people didn't identify that we were talking about the symptoms of grief because it's not so obvious when it's not a person that was lost. There's this profound complexity of layers of loss. And so the grief work is often complicated, and we're referring to ambiguousness and what could have been, and a lot of mixed feelings around it, like ambivalent losses. So it's really a very complex form of grieving. And I also want to remind everybody that because children grieve differently, that we often see them in different states, which are shifting sort of presentations. We might see something completely different one week and entirely different the next. And so it's easy to miss. So I want everybody to, not feel like you've missed it all this time. It's hard to figure out. And now you're getting increasing tools to be able to see it more. So grief work is an enormous one. Identity is huge. The ways that we think about ourselves and who we are incredibly powerful in terms of our behavior, our thoughts, our emotion. And we don't have time to talk about it today, but it is indeed a very core issue to working with this population. The intimacy piece, as children get older, their relationships are impacted. Somebody already put that in the chat earlier, and I'm sure many of you see peer relations, romantic relations, too close, too far, parental relationships that are impacted or impaired, all of it. And you see how it kind of all began with those original losses and compounded by more losses every time we move a child, for example, which is why it's so incredibly important. We're so committed to be able to fortify these families. And then the last issue, just a quick comment on the mastery control. I think many of you know that are versed in working with issues of control. You see this show up in many different ways in the work that you're doing, and it may well be an outcome of that original loss and an attempt to gain mastery over their world and their experience, because it really has been very out of control. So many things have been taken out of their control as they've moved, including that initial primal loss. So by the time we meet them, which is often fairly late in the game, it's now this theme of loss is now kind of creating this effect of a very complicated clinical profile. So next slide. what starts to happen is that loss begets more trauma, right? Because the more that I start to feel around these losses, the more that I start to become impacted, and it affects me as a person in some very painful ways. And so as I get older and I experience more of these losses and more of these traumas, as I said earlier, it starts to impact my development as a forming human being, because let's face it, my resources are all going towards trying to deal with the losses and the traumas instead of going towards my development, which, by the way, is my sole purpose as a child, right? Is to grow and to thrive. And yet all of this takes away because it's tremendous work, right? To lose people and to have experienced trauma. And I haven't even referenced the trauma that happens after they come into the world and are starting to grow up in terms of various forms of abuses that they might experience. So if they spend a lot of time in very impacted backgrounds or they continue to move, we all know that there's any range of traumas that they might have continued to experience, whether those be physical traumas, sexual traumas, psychological traumas, spiritual traumas, especially impacted by losses when they're not able to keep connections, whether those be to people, to places, to traditions, to activities, all of these things. And when I say people, let's remember the huge range of people we can be talking about too, whether they are biologically connected, like siblings, or not biologically connected, but people who really mattered to me, as well as all the layers of people that I didn't get to develop relationships for, but I really need later. Some of those elders in my community, for example, that might have made a difference. I don't get any of that. And so it continues to be experienced again over the life course as more traumas, more losses. Again, which is why that shame piece is something we see a lot in our work. Must be something wrong about me because other kids around me don't seem to have all of these life experiences. By the way, that's just a nod to services. I mentioned earlier that we don't want to be working in vacuums. I can't emphasize enough the importance of our work as therapists, but also support groups and all the other kinds of services that we can continue to offer to our families. It's really, really important, that systemic support piece. Okay, so lastly, just a quick nod to diagnoses. We talked about that for a moment earlier. In the next slide, you'll see this, what we call an alphabet soup of common diagnoses for our children. A lot of you shouted it out earlier. We frequently see these diagnoses. And the truth is that the complexity of the behavioral presentation, and sometimes the extremity of the behavioral presentation is so significant that we tack on more and more diagnoses. And it's an attempt for mental health professionals to understand. Diagnosing is really important in terms of understanding behaviors and to guide mental health treatment. But I think we also know that it's more of an art than a science. So children with these backgrounds have often been overdiagnosed, have been misdiagnosed, and the reality is their life experiences don't fit neatly into one category in our diagnostic manual. And so, sometimes as practitioners, we're not really able to just cleanly diagnose them, and as a result, miss or overdiagnose. So I know that because this is what's happening across, our country. It's not specific to any one person. If you're doing that, you're in good company. We don't necessarily have all the tools that we need. And unfortunately, what that results in, next slide, please, in child welfare, as many of you know, is an over-medication of children in care. So with all of these multiple diagnoses, it's kind of a recipe that children in foster care and coming out of foster care will be receiving a significantly higher amount of psychotropic medications. And by the way, this graph represents children under the age of 5 as well. Children in foster care have 2 to 8 times the rate of being prescribed psychotropic medication. Again, trying to manage those behaviors that can look so big and confusing and upsetting and hard, not underplaying that. And the reality that children not in foster care were being prescribed these medications at significantly lower rate. And this graph comes to us, you can see the the reference at the bottom. It comes to us for children who are in the Medicaid system. So we're not talking about, we are talking public system to public system, if that statistic matters to you. And then just want to point out, sadly, that 40% or more of these children were taking 3 or more medications at a time. That's a lot in a little developing body. Okay, so in the last slide here, I just want to share with you, there is definitely hope. This can all be learned in terms of specialty practice to rather address the core issues of what's going on, and going down some of these pathways that we've talked about that are common mistakes of mental health professionals. This is from our NTI class. You can see on the blue graphs where practitioners came into our mental health series, and the scores almost 100% in all areas of growth. The red were the ones where our mental health practitioners needed the most growth. They came in with the lowest scores. So areas around attachment and identity and understanding the backgrounds of children, like their cultural connections, those were the ones where our clinicians needed the most support. All right, so that in the next slide, you'll see more about our NTI training. And I'm just going to leave it there for now because our time is running short. I want to take a quick look at the chat to see if there is a way to just glance really quickly at the questions before Joaquin jumps in to give us some resources.
There are actually, Laura, 3 questions that we can identify right now. The first one was posted actually at the beginning of the webinar. It says, is there research on the effects of wilderness camps, on the effects that wilderness camps have on adoptive youth?
Aha. Okay. Yes. Wilderness camps are one of the many, many, many interventions. I don't have research off the top of my head, though, for that one. So that might be one that maybe you can email to the center, to the Knowledge Hub to see if we can get you anything more. Do you want to read one more?
Sure. I'll read the second one that I noticed was posted. For child welfare social workers, is there a trauma history template that is recommended to use and give to therapists so they have an accurate history?
Okay, this is another one that I think is going to be a little bit more complicated for the center. These are great questions for the Knowledge Hub. Yes, there are different assessments and templates that are out there. I would also refer you to the work of Dr. Kate Murray. The Murray and Sullivan tool is one that we talk about in our training, so we can get you more information on that, and there are others. Okay.
You want to tackle the last one?
Let's see. This time I can actually see it myself. We often know how to provide support to someone who's lost a relative to an illness. However, many don't know how to, but that's absolutely true, Gloria. The grief work is very complex. And unfortunately, we do not have all the tools that we need, including the rituals and the ceremonies. And the creating of memorials for all the loss that our children have experienced. So I'm not sure if there was a question in there, if I missed another question. But again, an important part of our curricula really is digging into the specialized kind of grief work that we do for this population. So on that note, I am going to turn it back over to Joaquin. There's so much more to learn and to talk about, and I really welcome you back into the center to really dive into the breadth of information that we have available. We just very lightly touched the surface today, and please feel free to be in touch. Passing it over to you, Joaquin.
Okay. Thank you so much, Laura. I just wanted to show you all these resources here. There was a question posted at the beginning. This webinar is being recorded and will be shared with everyone afterwards. But these are some of the resources that we have available at our Center Knowledge Hub. So if you want to take a screenshot of this right now, again, this will be shared with you after the webinar. And then also, if you could please take a moment to complete our survey, that will be awesome. Just take a few minutes. We're almost done here to do our survey. We would love to hear back from you. We would love to get some feedback. We would love to get your questions answered. For those that needed more in depth answers, you can reach out to us and we can get that information to you.